Good afternoon. I'm really honored that you are spending your Sunday with me. I am Bence Stubnya, orthopedic and traumatology resident at the Department of Orthopedics, and my supervisor is Zoltán Bejek, and my scientific methodology supervisor is Szilárd Vancsa, whose work I'm really grateful. And let's see what we did in the latest months. So our specific goal was to make literature research about the different surgical approaches performing during total knee replacement therapy. The second goal was to conduct a clinical trial, and we have an upcoming new project, which would be a randomized control trial at the Department of Orthopedics at Semmelweis University. Let's see our first study or first investigation, which was a complex systematic literature analysis about the topic of the different surgical approaches performing during total knee arthroplasty. Why is it important? Because the estimated growing of the total knee replacements is around 200–300%, but some of the articles mentioned around 500% increasing in the upcoming 20–30 years. But there is still no consensus about the more effective surgical approach regarding the early postoperative rehabilitation time. So we set up our questions using the PICO guideline, and we investigating patients undergoing total knee replacement therapy, and we compared the subvastus approach to all the other approaches, focusing on the standard use medial parapatellar and midvastus approach. And as an outcome, we investigated the range of motion, pain measured by visual analog scale, and some different scores regarding the life expectancy. Here I'm showing the Prisma flowchart, which is about our systematic search process. At the end, we were able to include 31 randomized controlled trial to our systematic statistical analysis. Our first examined outcome is the range of motion, where we compared all the data we found in the mentioned 31 randomized control trials in different cross-sectional times. We investigated day 1, 2, 3, 4, 5, 6, 7, 2 weeks, 1 month, and until 1 year. Today, I'm showing you the results of the first 2 weeks because in the early postoperative rehabilitation time found some significant differences between the different approaches. We can see that in the first 7 days, the subvastus approach is better, and in the most cases significantly better regarding the range of motion, which could really help the rehabilitation and the physiotherapy process for the patient, so they can return their normal life back earlier. Unfortunately, my figure is not easily readable, but the blue vertical line in the middle means the medial parapatellar approach, and the little boxes could be found on the right side means that the approach is better than the medial parapatellar approach. The horizontal black lines showing the confidence interval. So when the blue line and the black line does not touching each other, that means the significant difference between the approaches. And the the colorized rank plots means this is a rank plot where the approaches are ranking. The second outcome was the pain measured by visual analog scale. I'm showing you the result from the first year. The figure system is the same, and we found the same differences between the approaches. So we can report in our upcoming meta-analysis that both the range of motion and both the pain values are lower by performing subvastus or mini subvastus approach during total knee replacement in the early postoperative rehabilitation time. But this difference decreasing as time passing. Here I'm showing you two different outcomes which we analyzed as well. One of the surgical or the operation time, where we found that the mini subvastus and mini midvastus approach are significantly longer than the other approaches. And the other outcome which we analyzed was the straight leg rise, where we found that performing a mini subvastus approach, the patient could raise their leg significantly earlier than performing some other approaches. So at the end, we can say that we really strictly followed our predefined study protocol, but we have to say that we found 89 topic-related papers, but the data quality wasn't precise enough to eligible all the found articles. At the end, 31 articles was only eligible for the statistical analysis. At the end, as a conclusion, we can say that subvastus and mini subvastus approach are supporting fast-track total knee arthroplasty, and the QS, like the quadriceps sparing approaches, are superior to the other standard approaches. Yeah. We have wrote our article, which is under submission to the Journal of Arthroplasty. The second project was a clinical trial where the background of the trial was the same as during the meta-analysis. The questions were the same, and we investigated the subvastus approach compared to the medial parapatellar approach at the Department of Orthopedics, where we have a daily protocol during the hospitalization time. Let me show you our findings. We collected data and analyzing it, and after we can report that at our practice, the subvastus approach really has a significant difference compared to the medial parapatellar approach regarding a range of motion. So the patients really could reach a higher degree in range of motion in the first week days. The second one we measured is the pain using the visual analog scale, and we can also report that patient in the subvastus group had lower pain scores than in the medial parapatellar scores, and this difference was significant in the first 6 days as well. Yeah, and we measured the pain during active movement and in rest as well, and in both methods we found significant differences. As a conclusion, we can say that subvastus approach is superior to medial parapatellar regarding to range of motion, pain, and painkillers need. We have written our manuscript, which is under submission as well. As a third project, we did a retrospective analysis of the number of total knee replacements in Hungary regarding the last 10 years, where we found that the number of total knee arthroplasties performing in the national healthcare system in 2010 was around 4,000, but in the last COVID-free year, in 2019, the total knee replacement therapies were more than 12,000, which means 300% increasing just in the last 10 years. So this is our progress in the last 15 months. I'm really happy to have the opportunity to share with you my research. Thank you for your attention, and I wish you everyone a Merry Christmas and an impact factor-full New Year.
Thank you very much. I think everybody here in the room knows that the range of movement is very important, and also the hospitalization stay, but also the placement of the different components are also very important, because it can be, for the long run, an influencing factor. Did you include it also, the placement of the different components, the tibial and femoral components? It was also an indicator in your study?
During our meta-analysis, we only focused to the range of motion and the pain values, but there is two meta-analyses investigating the malalignments of the total knee replacement, comparing different approaches. And the two meta-analyses published in 2020 and 2021 report that the malalignments are a little bit more frequent using QS, so quadriceps sparing approaches, but the other meta-analysis report that there is no significant differences between the different approaches regarding the malalignments.
Mm-hmm. Thank you. It's a very important point of view. The second question is that you mentioned that it was a decrease in the difference of the range of motion and pain. In which distance and when did the subvastus approach reached the same results as we would have had in the straight incision?
Yep. So based on our results, we can say that after 3 or 6 months, the significant differences between the approaches are gone. So after 3 or 6 months will be the same values between the different approaches, but we saw some meta-analysis investigating these outcomes like range of motion pain regarding the 6 months or 1 year, but we focused, or we aimed to analyze the early postoperative rehabilitation, because we really would like to know which surgical approaches could offer the best rehabilitation to the patients.
It was also very interesting to see one of the table you presented, that the difference between the pain between the two approaches after 5 or 6 days already were almost the same. So very little difference was seen.
Yes.
Is that true?
Based on our results, we can say that it's really close to true.
Yeah, okay, okay. Thank you very much.
Thank you.